Hello, everybody, and welcome again to JSCAI. It's a pleasure to be here with you tonight. I'm delighted to be here with an awesome panel to talk about chronic venous disease. My name is Sahil Parikh from Columbia University Medical Center in New York. We're going to start by introducing tonight's manuscript and our speakers. Dr. Robert Attaran is an associate professor of medicine at Yale University School of Medicine. We're also delighted to be joined by Dr. Sanjay Misra from the Mayo Clinic and Dr. Ehrin Murphy from is it Atrium Health? Atrium Health in North Carolina. We're really excited to have a multidisciplinary panel here to talk about chronic venous disease. So without further ado, Rob, why don't you go ahead and tell us about your review article in this month's JSCAI?
Thank you very much, Sahil. It's a privilege to have the opportunity to present this recent review article to both the JSCAI readership and to this wonderful panel. This article is now available for free download online, and I'm presenting it on behalf of myself and Dr. Jeffrey Carr, my co-author. I think this graphic very nicely sums up from a bird's eye view what venous insufficiency of the lower extremities is about. It is a condition of ambulatory venous hypertension that can result from both obstruction, reflux, or both, and that the sum total of that can lead and be associated with inflammation, even thrombosis, and a whole variety of symptoms. And this the readership will be familiar with. And what we've also added to this separately from above is obesity, which I think is an entity of its own, but many individuals with obesity that we see in our practice do have signs and symptoms of venous disease without necessarily, say, having reflux. This paper really summarizes a lot of the key facets of venous disease and puts it all together. First of all, the disease burden, as you will all know, is extensive, probably more common than peripheral arterial disease. Many Americans have it. Very expensive. Over 2% of Medicare beneficiaries have venous ulcer disease, and there's a payer burden of over $15 billion a year. The pathophysiology is quite fascinating, and there's the ambulatory venous hypertension is thought to lead to venous remodeling, to white cell leukocyte infiltration, as well as inflammatory processes that go on. Not to mention that the elastic components of the vessel walls can be diminished. The condition can be divided into superficial and deep, both reflux and obstruction. In this manuscript, we discussed quite extensively the role of compression, which remains a cornerstone therapy in venous therapies. We talk about what it means for someone with milder disease as opposed to more advanced disease with ulcers, what the benefits might be after an intervention, and also what the benefit or the role may be in post-thrombotic syndrome. We also touch upon medical therapies that are not always given much attention, the so-called flavonoids or venotonic agents that are out there. Some are thought to be anti-inflammatory, some are thought to reduce capillary permeability, etc. And of course, we discuss various invasive treatments for venous disease. I think it is important for anyone interested in venous disease of the lower extremities to be aware and to personally utilize classification systems, and to utilize a symptom score of some kind to improve reporting consistency and to frankly see whether their treatments are working. Another important area that we see, particularly with somewhat older patients, is the so-called mixed ulcer, where there's both peripheral arterial disease and venous insufficiency, and we look at some of the data out there on how to approach these patients best. We talk about all forms of ablation modalities and the evidence for them, the thermals and the non-thermals, and how they emerged and what's been their outcomes so far, who they're good for, and perhaps who they're not so good for. We talk about sclerotherapy, and we discuss that in various settings. And of course, we talk about the ever-growing topic of iliacaval stenting, both in post-thrombotic disease and in non-thrombotic patients. And of course, there is a lot of interest here. There's been a lot of growth, but there still are many questions to answer. How to best take care of post-thrombotics, whether and which type of patient with C3 disease would do best with one of these stents, and why do some patients not improve? Why do some patients get restenosis, so to speak, within their stents? And finally, and we've seen that the field of venous intervention, both superficial and deep, has really taken off over the past 10 or 20 years. There's been an increase in interest and study. Cardiologists and interventional cardiologists have been performing more and more procedures, and as stakeholders, they really are now at this point in time a major stakeholder. However, the truth is that many of us are still practicing venous care in a silo, in a bubble. There are a whole host of reasons for that, but ultimately, I think one may be that for ablation alone, the bar for entry has traditionally been quite low, and many people have started to do it with all the right intentions, but may not necessarily appreciate the nuances and which patients the ablation may be best suited for. And they may not necessarily have appreciation of deep venous disease and other factors in play, perhaps lymphedema, medication side effects, other comorbidities. So as you will know, various societies, including those in radiology and vascular surgery, have guidelines on the management of patients with venous disease. And we in SCAI have joined with the Society for Vascular Medicine and have now embarked on a guidelines effort. And over the next year and a half, we will have the opportunity to come up with a joint guideline document to assist cardiologists and interventional cardiologists in venous disease care specifically. And this will be tailored with the latest evidence in mind, and of course, with the cardiologist and interventional cardiologist in mind. And along that, a group called the Venous and Lymphatic Medicine Work Group was formed in 2021 by Dr. Zoe Diol and a number of other stakeholders and various leaders from vascular surgery, interventional cardiology, and interventional radiology. And the aim is to improve venous and lymphatic medicine training and education from the fellowship and residency level onwards, and to create a document that creates a curriculum, if you will. And the various stakeholders now include the ACGME, the American Board of Medical Specialties, and a number of other societies. And the aim ultimately is to improve the training and the recognition and to turn venous and lymphatic medicine into a specific specialty recognized in its own right. Thank you very much for your attention.
Rob, thank you. That's a terrific introduction and overview. We're delighted that you have taken the reins of this to lead, but as you pointed out, this is a team sport, and there's a number of different groups that are taking care of these patients. I want to give both Sanjay and Ehrin a chance to talk about their perspectives about where the state of the field is and where some of the unmet needs are, both for education of referring physicians and practitioners in the field. Maybe Sanjay, I'll start with you, and then we'll kick it over to Ehrin for her opinion.
Yeah, so thanks again for the invitation. I think a couple big points. One, venous disease is more prevalent than arterial disease. And I think it's a huge opportunity to help patients. I can tell you, even at my own institution, my wife had saphenous vein reflux, and she's a small petite woman. And it was really underappreciated at our own institution 10, 15 years ago in the utilization of ablative techniques. And so, and those technologies and utilization of tools and diagnosis have changed. Initially, they thought she may have POTS and other factors. And so I think, one, we need to really be sensitive and be hypervigilant that we're not missing this. So diagnosis is really important. Number two, having adequate tools to diagnose, accredited labs. Where we are, we've got accredited labs. We're in a vascular center. And then number three, having expertise. I'll tell you, I'd like to do deep venous reconstruction over superficial venous management. And so, and our own colleagues are certified. And so I think certification is really important. And then the other part that's really important is understanding mixed disease. Those of us that do critical limb ischemia, patients will come with arterial and venous disease that are overlapping, and really important to understand that. And the last component that you alluded to, Rob, is the obesity pandemic and this interaction of obese patients that have venous disease that can be difficult to manage, diagnose, and treat. So those are my big points to start with.
I'll add, I think the field of venous surgery and venous care overall is so new. Then it's so new that even the people who are experts in the field like us, we didn't train in it, right? Where the field is still being developed. So I think articles like this are very important as people are coming in to see an overview of the whole space, because where people have entered is, as we've mentioned already, is rather fragmented and separated, all by specialties, but also by just what aspect of venous disease you're treating. It's the only field I can think of where there's people just treating superficial or just treating deep or just, managing medically with compression, completely unaware of the other options out there. So I think an overview that opens everybody's eyes to, you need to know all of this to know how to really care for that patient specifically. Somebody may have a 2 millimeter saphenous vein that you could ablate, but they have an iliac occlusion. You need to treat that. Somebody may have, a 50% May Thurner, but they've got a 1 centimeter refluxing GSV, making their leg feel heavy. So being able to weigh those options and being able to understand the whole field and all the fields coming together via creation of these boards and training programs, whether you're cardiology or vascular or interventional radiology, we all can come together on this to get good standards of care and good training programs. So I think this is a great start.
So one of the important things here is to understand that venous physiology is a discrete entity. I think that we in cardiology are very attuned to central venous hypertension in the context of heart failure. But once we get below the cava, things start to fall apart in terms of our education. And so I think that, Rob, you have led the charge here to put a flag in the ground regarding the essential components of education and specifically understanding from the biology and physiology all the way to the clinical entities for intervention. Where do you see the biggest gaps right now in terms of education of interventional cardiologists in this space?
I think the biggest gaps are, and as you probably know, at Yale, I'm both the interventional cardiology and the endovascular program director. And I think even within endovascular programs, from what I've seen, many do not spend enough time or nearly enough time on venous education. So I think that's one obvious area where there's a deficiency. I've had several of our graduating fellows subsequently send me a text message saying, hey, oh my gosh, I've got all these venous patients and now I don't know what should I do here? And we're happy to mentor them. And I think mentorship is very important. But I think one is to increase in all those specialty training programs the amount of time spent on venous disease. And then there are certain things that cardiologists can easily do to bring value to the equation. For example, if we're performing for the past, I would say 7 years or so, if I'm performing a deep vein IVUS to look for a non-thrombotic lesion in a patient with, say, edema, I will also almost invariably put a Swan-Ganz in and measure their hemodynamics. There are many people who will be diagnosed with occult diastolic dysfunction or something else that can be actionable if we do that. So I think there are things we can do. So to increase the amount of time, the dedication to it. In interventional cardiology, if you don't want to be a CTO operator, for example, that's okay. You can do other stuff, but you're expected to know pressure wire and intravascular imaging and et cetera, et cetera. In venous disease, as we've seen, there are people who will just do ablations or just do deep vein or not even have awareness or enough awareness of other things such as lymphatic disease. So I think that needs to become much more comprehensive.
Well, so for the trainees out there, I would just put a tickler in that there's a advanced training statement that's going to be published in February of this year. That's going to have a lot more granular detail about educational points on both arterial and venous disease, in addition to other interventional cardiology topics. All right, so we know we need to educate people more, but there's an incredible amount of excitement in the area of innovation in this field. So let's go from the basics to the really advanced stuff. Ehrin, what's the most exciting development in the field, and where do you think the field is going to be in the next 5 years? What's got your interest?
Well, I think clearly what's motivated the interest in venous disease has been the new development of venous dedicated stents over the past few years, right? And much easier to treat these patients. I think we still have a ways to go. We need caval stents for these patients. We need potentially an iliocaval system. We need more knowledge and more ability to treat our lymphedema patients. So if there's any, upcoming technology in that direction, I think would be really valuable. And I think honestly, there's still a ton we have to learn about which patients to treat and, the research side too, not just technology. Sanjay, what do you think?
No, I agree. I trained with the wall stent. I'm dating myself. And so I think once, we're going from wall stents, Z stents to all the dedicated venous stents. And I think technology is catching up. I think there's also biologic implications for stents and how does the vascular remodeling occur? Why does vascular stenosis occur? What are the implications for antithrombotics and inflammation? I think an area that's really missing, if you look at even the ATTRACT study, is, what's the implication of venous thrombosis and inflammation, and how does that imply success or failure, especially when you're looking at quality of life and other readouts. So I think there's a whole area that's really missing beyond just technology. And I'm waiting for the technology to now start embracing what we've done in the coronary and the peripheral arterial world with, drug-eluting technologies and other things. And I'm waiting for that to happen because I think there's dedicated areas for improving our technology for veins. So those are the areas. And then the other point I'll make is, there's so much ablative technologies that we have, whether it's a laser or embolic. This is superficial venous disease. Are they all the same? Are there implications for using one over the other? And so I think those are going to be areas that we may see changes, especially with reimbursement. If reimbursement dictates, what we can use in the OBLs or in the hospital, we'll have to get the cheapest technology maybe, or the cheapest, most effective with the best outcomes to be utilized. So those are some areas down the road that may have implications depending on where you practice.
Rob, I'm going to give you the final word. I think this is an area that is growing explosively, as you pointed out. What's got you really excited about the future of venous disease?
I think the most exciting thing is that we are entering at ground level. It's kind of the way interventional cardiology was in the late 80s or 90s. There is so much more to learn and do that I think it's a wonderful time to enter the field.
Well, that's for sure. I think we've seen explosive growth in this area, and we would encourage all of our interventional cardiology trainees and practitioners out there looking for opportunities to help take care of patients with unmet needs to look at venous disease. And hopefully, Rob, your paper is going to be the tip of the iceberg to get people interested. We certainly encourage everybody to look at Dr. Attaran's manuscript in JSCAI, and then join us at the SCAI Scientific Sessions, where we're going to have a deep dive into chronic venous disease in a number of different sessions. So with that, I want to thank everybody for your kind attention and for your time. And I want to thank our expert panel for their time. And we look forward to seeing you here at JSCAI next time. Thanks very much, guys.